My name is Tal. I'm a GP for my sins. And I'm going to... There's only a handful of us here. And you're all obviously not really paying attention. So if you're not paying attention, I'll ask you to share what you're doing with the rest of the group, as I was told many times when I was little. But anyway, I'm just going to say a few words, predominantly about the medical innovation. Does anyone see? I'm not sure if you're old enough, some of you. The Christmas lectures used to be on, and there was somebody who did the lectures, and there was somebody called Bryson, I think it was, who did the stuff in the background. He was getting all the stuff ready. Say no more. What's the name of this? Yes, that's right. Yeah, and he did all the work, and he didn't really get a whole heap of credit, did he? So, yes. I will take full credit for all this. Anyway, I'm just going to say a few words about the medical innovation research opportunities. This is predominantly for students. Are you guys at the back students? And are you presenting shortly? You realize that we're judging. And we're very, very harsh at judging. We've already got like criteria of how we're going to mark you and everything. And I think it's a fantastic opportunity for you guys, but also for other people in future years, because it gives you a chance to put yourself in a place where you're uncomfortable, but kind of safe as well, I think. And this is a place where you will get lots of people who will support you and stuff. So I just wanted to say, I've been asked to say just a few words about the benefits of joining. Perhaps I'll open it to you guys. What are the benefits of doing this? It's stressful, isn't it? How have you found it?
I guess we get to showcase all the hard work that we've done for our research project.
So for those at home, get to showcase the hard work that they've done on their research. Somebody has told you it's 3 minutes, yeah? So I think to be concise, I mean, I'm obviously waffling at the moment, so but to be concise is an art, and I think people have very short attention, especially youngsters actually have very short attention span. So I think it's a good skill to have, and I think there are a number of prizes, aren't there? So submission, you need to submit it on time. You get to meet different people. You get little certificates that can help you with your career. I think it does actually. It just shows that you've presented at a conference. I think it sets you apart from other people who, it is getting comfortable with rejection stuff, something that I've spent a lot of my time doing. It's an art. And some of you will walk away with cash in your back pockets. £100, I think. That'll not quite enough to get you a iPhone 13 Pro Plus with cinematic video, but it's on the way. Every little helps. And I think there's £50 for the second, and £25 for whoever's third. And there's an extra prize, isn't there? Having lunch with Professor Shafi and Barry. That's definitely worth more than £100. Like, especially if you're students, just eat as much as you can. The band say, actually, it's at the Ivy, isn't it? Not normal Ivy. It's the private members bit upstairs, which students can't get in. So it's a student-free zone. And your NUS discounts won't work there either. Anyway, I was just going to say that's it, really. So you guys know about the program. If there's others watching at home, come along and you can submit your application. It's only 250 words, isn't it? To apply, and it'd be fun. So the next talk is, I think, really, 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 really helpful. So building on some of the presentations that you guys are talking about, actually presenting at a conference is great, but maybe you can present at in a reputable journal. So and they've actually made it much easier to be able to submit publications on innovation. So I think it's over to VT, and this is a really good talk.
So welcome, it's really great to be here, and a big thank you to Tom. It's really great to be here, and a big thank you to Tom and the Giant team for the invitation. I'm going to talk a little bit about some of the healthcare innovations from during the COVID-19 pandemic, and those that we think will go on to make the biggest impact on health by 2030. By way of introduction, my name is Ashley McCabe. I'm editor-in-chief of BMJ Innovations, which is our relaunched specialist journal focused on digital health, medical devices, and process and system innovations. And I'll be reflecting on some of the papers that we published in BMJ Innovations and more broadly at BMJ over the last 18 months. So in starting this session, it's difficult not to first reflect on the fact that actually for us as healthcare workers, it's been a really tough 18 months, probably the toughest period that many of us have faced in our lifetimes. Recorded deaths from COVID-19 are now well above 5 million, but we're hopefully finally starting to see some of that progress towards a more normal 2022 with the rollout of vaccinations globally. So with some caution and not forgetting the horrific impact of COVID-19 and the lives it take, I'm going to start to look a little bit further forward in some of the positive innovations and some of the positive future that might evolve from COVID-19 as we move towards 2030. But before we jump forward, I want to jump back, way back to 541 AD and the city of Pelusium in northern Egypt, which is where the first recorded pandemic occurred. It was also known as the Justinianic Plague, and it raged throughout Europe for almost 2 centuries and killed between 1/3 and 1/2 of all the Europeans. This and the pandemics that followed really were the start of innovation with regards to public health. And we saw incremental steps forward, starting with the basis of quarantine and health protection. And as the saying goes, necessity is the mother of innovation, and wars, pandemics, sustained climate events all drive innovation. The third cholera pandemic that took place in the 1800s really gave us that start of that focus on public health. And the Spanish flu of 1918 gave us the International Bureau for Fighting Epidemics in Vienna, which was the precursor to the WHO. Just before we move on, I want to talk a little bit about BMJ over this period of time. And you can see that we had a huge increase in submissions during the pandemic, an 85% rise in the number of papers. That obviously doesn't translate directly into improved health outcomes, and it isn't all COVID papers, but I think it's really interesting to see the amount of research that was really spurned out during this period. So let's come back to COVID-19, the first pandemic where the rapid deployment of technology and particularly digital technology became a core component of how we tried in the race to understand, contain, and deliver a potential pandemic. And looking back in COVID-19, it's likely we'll see this as the digital health pandemic. So I think as people working in this field and healthcare startups and digital health, we're in a really interesting place. It probably seemed at some point that every country had their own variation of track and trace. We had people zooming in to see their doctors and having healthcare consultations, and health shifted online wherever possible. We saw huge advances in AI and big data trying to tackle the disease. And as you know, many of these innovations failed, but like past global crises, many will evolve to play a permanent role in health beyond COVID-19. And I'm going to very briefly, given the time we've got today, touch on 4 that I think will have a bigger impact after COVID-19 than others. And those 4 are, unsurprisingly, vaccines, telemedicine, the evolution of AI and big data in health, and finally, social media. And I realize these are probably a controversial choice. You'll have your own opinions, but these are 4 that we'll be focusing on in the journal going forward. Before we dive into those, I think it's probably just worth keeping in the back of your minds 5 factors from normal times, and there's various different versions of this list, but 5 factors that are attributed to low impact and slow adoption of technology in healthcare. And these are regulation, unsurprisingly. Number 2, which is the risk aversion. So again, not surprisingly, the worry about safety and the risk aversion to trialing new technologies, which is why often the technology is often last or later to come to health. The third one, probably more so outside the UK, but payment structures that are really geared to quantity, particularly in the private sector, rather than quality. And quite rightly, a fear that many clinicians have that new technology will impede them, slow them down, take them time to get adjusted to it as well. And finally, the concern that technology often interrupts that patient-doctor relationship. So keep this in the back of your mind as we move forward. I'm going to start with our first topic, which is the most obvious one. And I think if we went back 18 months ago, we thought it's impossible that we have one vaccine, never mind to being very close at the minute to delivering 8 billion doses globally. Where we've got to is really a decade's shift in our understanding and rapid development of vaccines through new technologies. You'll see in this screen grab taken from, this was the New York Times back in April 2020, you'll see that we've gone through squeezing a 10 to 15 year cycle for vaccine development into a couple of years, and we've compressed that into such a short period. And if you look at the detail, you'll actually see that even back in April last year, whenever we were really seeing the rapid development of vaccines and mRNA vaccines, that we still only anticipated that the vaccine would only be completed in August 2021, and actually we had the first vaccines being delivered into people 9 months earlier. And this isn't just really a freak occurrence. We've seen a fundamental paradigm shift in our understanding and the methods of vaccine development. The Pfizer-BioNTech mRNA vaccine is a leap forward in the rapid development of future vaccines, and you can see that actually compared to previous infectious disease outbreaks globally, previous pandemics and epidemics, we've never achieved this before, and we've come nowhere close to doing that. And you'll see that actually some of the technologies that we've developed during COVID will hopefully go on to tackle some of those diseases that we haven't managed to solve. mRNA vaccines are a huge step forward for many diseases, but even traditional teams, the Oxford team, are working on the first trial for the HIV vaccine going forward. So we're seeing a huge amount of evolution and evolvement in that space. And it's not just on the molecular side. Artificial intelligence was applied to lots of things in vaccines, from supply chain management to understanding uptake. And particularly in the UK, it's also using AI to go through all the side effects. We're using AI technologies to look for trends and correlations in side effects for vaccines as well. So lots of really exciting things that are happening. And beyond that, other technologies that we're using in digital health, like blockchain, being applied to vaccine passports as well. So lots of exciting things happening in vaccines. As we go through this, I'm going to just also touch on some of the challenges, because I don't want to be too optimistic about where we go by 2020, 2030. Some of the key challenges in vaccines, we've seen this over the last 18 months. Inequalities in vaccines have been a big challenge, with many rich countries being able to jump the queue and have access to vaccines, and that's argumentably holding us back in how we tackle COVID at a global level. There's also been that difficult balance between the private and public sector and that ownership of IP that we've seen many commercial entities, drug companies, making a decision about whether to realize a profit from vaccine production or not, but also restricting the production of vaccines, and whether governments protect the investment that pharmaceutical companies make into vaccine development as well. And finally, the ongoing one, the big one that we're seeing, particularly at the minute, is public trust in the safety of vaccines and vaccine hesitancy, which we're trying to address. So those are things that we still need to overcome. We'll come back to some of those as we move forward, but I want to move on to talking about our second topic, which is remote healthcare adoption, so telehealth. And there's been a huge amount, again, in this space, a huge amount of shift towards telehealth, and primary care or outpatient care has always held the promise that they could be largely delivered digitally. But COVID really precipitated this in many countries, and many countries decided to take a digital first approach during the pandemic. Here in the UK, if you looked at data back in December 2019, just 15% of our 23 million primary care appointments took place by phone or online. Even by April, only 4 or 5 months into the pandemic, we had a huge shift where this had jumped to 50% of all appointments. And by September, this was up to really 90%. This is a paper from BMJ Health and Care Informatics, which looked at the reasons for that and why we had such a big shift. But a lot of these were pretty obvious. And the reason we were able to adapt quite quickly was because we had to. That we adapted many softwares that already existed. We didn't start from scratch. We took things, and you might remember if you did see your GP during the early stages of the pandemic, that it may not have been a smooth experience, and you were using cobbled together technologies to make that happen. And that was possible because many countries relaxed their privacy and data protection technologies to allow this to happen. Partly because, the third point there, that there wasn't supposed to be or wasn't allowed to be any physical interaction. So all that care had to really move to virtual medicine. So, some of those things are very obvious, but it became much more challenging if you're in a low-income country. So we shouldn't really exclude the fact that actually there was lots of frugal technologies that were adopted in many parts of the world. So it wasn't just telemedicine in rich countries. There was lots of text-based technology that was there. There was lots of symptom monitoring, tracking, tracing that happened through open access platforms for managing, COVID that was developed. And we, I think we published lots of papers that you can go in and read around how we developed and how teams developed low-income country technologies for monitoring both COVID, but also managing things like treatment of long-term conditions via telehealth, and also using things like smartphones. Medical students and teaching ground to a halt. And there was a number of innovations that really helped to continue medical education with virtual ward rounds using smartphones and communication tools like that as well. So lots of really interesting technologies. And this is one that we covered in Nigeria, which was an AA-based telephone service. So not all of this was telehealth. Some of this was using traditional technologies, but this was a service company that was based in Nigeria, in Lagos, and they managed to turn the technology to handling thousands of callers every day who had questions about COVID symptoms and treatments as well. Again, none of this is straightforward. That we have seen and potentially will continue to see an exacerbation of health inequalities in this space, that it really caters to people who are tech savvy. But it's been surprising during the pandemic the number of people who managed to jump across and use Zoom for the first time who had never used that before. So we did see a lot of technological advance from individuals and what was acceptable for them to engage with healthcare during the pandemic. Data insecurity and privacy, a lot of people became more relaxed about that during the pandemic, but we're wondering whether whenever things restart that will continue and people be more worried about their confidential healthcare information going forward. And finally, there's still a huge lack of comparative studies between telemedicine and face-to-face medicine. COVID probably wasn't the best time to test that, but we need more studies to look at the evidence of treatment safety and the effectiveness of telemedicine care. The third topic we're going to look at is the role of artificial intelligence, particularly in the prediction of disease. And we saw this rapidly evolve during COVID, and we saw multiple pivots in the AI space. of many companies coming into healthcare for the first time, but also many companies who started on everything from molecular AI moving into diagnostics and radiography and various things as well along the way. We've covered this in many different journals across BMJ, and we'll continue to do that. One of the companies that we visited just before the pandemic was Blue Dot, a really great Toronto startup that was credited with being the first to recognize that unusual cluster of pneumonia cases in Wuhan before official sources confirmed this as being COVID-19. They use lots of AI algorithms to scarf foreign language news reports, animal and plant disease networks, and they alerted the world to COVID on the 31st of December, as did another firm, Data Miner, on the same day. But Blue Dot also went on to predict 10 of the 12 cities first to be impacted by COVID, and they're still going on to, I think, currently mapping over 200 diseases in real time. There are many, many other companies, AI companies, that applied their tech to COVID. Quite a few worked on diagnostics and giving a better understanding of diagnosis of COVID-19, such as this one here, which was to differentiate that between COVID and other diseases. There was also a rapid innovation into the space by AI for molecular and the biolife science industry. And many of those were about coming up with new drugs. In Silico Medicine, which is a Hong Kong-based organization, used AI to run through millions of molecules to look at which ones could be effective in treating COVID. And the other interesting bit was that there were many, many attempts to use track and trace. Many of those used big data, many of those used AI and machine learning to analyze hotspots and shape the public health messaging. Not going to go into track and trace apps. It's a whole another presentation for that, but there's been a lot of failure here and also learning for next time too, going forward. So big challenges around COVID. Going back, we've had restrictions, as I sort of said, relaxations on privacy, and will that hold back future innovation? Will this shift of companies into health supercharge growth? So we've seen, since last year, a huge influx of funding of VC money into health tech, particularly in digital health, telemedicine, and also in the AI space. Will that continue? Will that continue to supercharge that growth? And will we be putting back in some of those safeguards again? Some of those rules of fast tracking drugs. Will that continue, or will we put in new regulation that may slow things down, for some obvious good reasons going forward? And finally, I want to touch on number 4, which is social media. And I realize this is probably a strange one to talk about in the terms of digital health innovation, but I think COVID-19 really accelerated some of the key regulatory and purpose-based discussions for social media, and it really soared. If you look at this is from Hootsuite, but if you look at social media use during the pandemic, it was up, between 30 and 60%, depending on what sort of media you look like. And it wasn't just about the time spent; it was about greater content creation too. Some of this was very positive. It was a story really of two halves. Rare examples of excellence. This was one from Vietnam, where they used pop stars, music stars in Vietnam to create a video message about hand washing, keeping your distance, and precautionary measures to avoid infection with COVID. And it went viral both inside and outside the country, 21 million views. And it spawned similar campaigns in places like the Philippines and Singapore as well. There's a full study into the impact of the behavior change on this being published early next year. And there was also a lot of work on addressing health misinformation and using AI to address fake news, and BMJ covered that, everything from how social media companies were addressing this to how it tackled vaccine hesitancy across that journey. The good thing was we got very much better at finding fake news during COVID. There was a huge increase in fact checking by the social media companies, by Facebook, by Twitter, and they were able to spot a lot of them, but actually it was very difficult because what they realized was that some of it was not completely fabricated, some was based on existing information, which made it really, really difficult as well. During COVID, we had various public figures, presidents, who were also peddling healthcare information. And actually, if you look at the overall trend of social media engagement, it was quite a small number, 20% of public figures accounted for the bulk of social media engagement around health misinformation. And the social media companies really, really struggled. They all started carrying messaging later on, and many of them invested a lot of money in fact-checking services. Many actually, employed a lot of staff to go through and remove health misinformation, but it remains a struggle, particularly, more so now in countries that don't have English as their first language, or countries that don't have huge audiences where those media companies would invest money. So countries that have smaller populations with unique languages, often you'll find that actually there's very little fact checking or removal of posts taking place. I'm not going to go to this slide in too much detail, but the use of social media networks is really diverse, and it's many areas that we've seen health misinformation sort of slip through the gap. Governments and regulatory authorities that try to put in place regulation. The EU took a number of steps forward, and they, along with the World Health Organization, called on social media companies, and the EU took a more tougher stance with making sure that social media companies removed health misinformation and dangerous content. But there was, I think, probably for the first time during COVID, regulations were brought in to start to help to manage health misinformation as well. And health, people like Facebook started to actively remove incorrect information from their platforms as well. So, social media will continue to play a big impact on vaccine uptake. It will, play a big part in health misinformation, over the coming remainder of the pandemic and right through, in the future as well. There, I think, needs to be that balance of continued, openness of these platforms, but also greater industry regulation. And you'll see that the EU and the US, which actually just this week had a congressional inquiry into, social media use and health misinformation, that will continue, and actually we'll probably see greater regulation of the sector going forward. The bit that we talked about Vietnam and how they used it positively, but I think there's a recognition that actually to fight health misinformation, the governments and official bodies for public health need to really leverage this platform more to share positive messages about health. And the role of health influencers, doctors, in being able to use this platform to communicate positive messages for patients about how to manage their health and communicate the argument for vaccines to those who are vaccine hesitant as well. So that's been a very quick fly through of 4 areas that potentially will have a big impact past 2030 and past the pandemic. We're continuing to look at these in BMJ across all the journals that we do. Vaccine will continue hopefully to see huge paradigm shifts in vaccine development for many conditions that we haven't managed to treat, from cancer to malaria to HIV. Telemedicine, as the world goes back to wanting to meet the GPs in person, there will be huge advances in telemedicine alongside that and virtual diagnostics. We saw just last month that Babylon, probably the biggest telemedicine provider in the UK, went public with an offering on the NASDAQ and raised well over $4 billion that will sort of, I think, help to advance this field very quickly. AI, which is continuing to evolve and play a big part in healthcare, is becoming a really important part of drug discovery. A lot of that evolved in the COVID pandemic around sort of molecular diagnostics, and we're going to see, I think, that field evolving. And finally, despite all these fantastic new technologies, that actually it's a lot about the trust of the public, and being able to understand how they can benefit their health, and really sharing trustworthy evidence-based information to patients as well. So these are the 4 areas that we picked out at the BMJ. These are areas that we're going to be focused on going forward in our journal, BMJ Innovations. So please do follow us, and also I think please do share your work. We've created a new type of publication within BMJ Innovations called Early Stage Innovation Reports, which are specifically for healthcare startups, digital health companies, to publish that early stage work before going on to clinical trials. So do come and speak to us, and hopefully if you follow us, you'll hopefully see some of that really early emerging innovation in healthcare as well. So thank you for sitting through this. I think hopefully this is a bit of a taster for the rest of Giant today and tomorrow. And hopefully will be something that many of the other speakers will delve into in more detail. So thank you for joining me, and look forward to seeing some of you in person over the next couple of days.
Just wonder what thoughts people have on some of the innovations that has been identified by Ashley. I mean, social media isn't something that appears necessarily. I just wonder what the youngsters think about that. So Tony, we don't need any comment from you. No. What do people think about the role of social media? I wouldn't have put that in the top 4, but do you think it has a role? And feel free to articulate that. Can we get a mic? We've already got a Tony. We need a mic. Sorry, I can only make fun of you so many times, Tony. Just shout.
Social media is where everybody's already present, so we should use that to communicate and reach out to patients.
In the language that they're familiar with, actually. And I think rather than us inventing stuff, so could you be the roving mic? If you could take it, like this. Sorry, go for it.
No, I was just going to say that younger people, I think, use social media more than actual newspapers or online and like BBC, etc. So I think the fact that there's so much misinformation on these websites, particularly at the beginning of the pandemic, so over 20%, is actually significant, and that could be one of the reasons why there was such a decreased rate of uptake of vaccine in younger people. So I think that I didn't know it was that high, to be honest. So yeah, I found that really interesting.
And what you have is a situation where youngsters are sophisticated users of social media and healthcare. Oh, sorry, you got to keep mobile. We're gonna wrap this up in a minute, but you got youngsters who, I'm sorry, I'm being facetious, but you got patients who are sophisticated users of social media, and healthcare professionals and organizations who absolutely are not. They're not speaking the right language, not communicating. They're a bit afraid.
No, I think the figure on kind of the public figures and celebrities is really important. I think that's something that's really, really under addressed. The people who are influencing people are influencers nowadays, and those are unfortunately not medical professionals, and we're not going to change that. What we need to change is how we interact with influencers so that we can talk to the people, because people might not follow your company or the trust or NHS England, but they do follow, the whoever was on Love Island.
So what do we need to do?
We need to interact with influencers.
How?
Because they need to be educated first, so that they can then educate others.
Can we be influencers?
Yes, we can.
How?
We can, you can grow followings. You can, build kind of an organic following, but there are a lot of people out there with massive followings. And when they, kind of naively often, I would assume, misinform, that's something that needs to be addressed. And it needs to be addressed more with kind of like compassion and knowledge, rather than just saying, well, this person said something wrong. This idea of kind of like shaming people just because they're not, medics.
So that's food for thought. I think this is a fascinating conversation. I think we've got a lot to learn from the US, and that will come over here. And the US big institutions are starting to use social media much more. And in a couple of years' time, I bet you will have a social media stream. But until then, we have a live demo. I would like to introduce you to some learned, old-fashioned physicians. Well, technically, you're not a physician, are you? A surgeon.
No.
So allow me to introduce you to Medical Chain and My Clinic.
No, I think you got the wrong one.
Oh, Rajesh,
Yes, that's
just come through with it. What's wrong with you?
sure. Okay. Afternoon, everyone. Thanks to the team for the invitation, and it's a pleasure to be here, joining you all in this amazing event, which I think it's one of the best conferences I go to in a year, the transplant and everything. So I'm a transplant surgeon. I work at Barts Health, NHS Trust, and really, I mean, I've been interested in technology and how we can use that to innovate healthcare generally, and more focusing on remote healthcare for patient care, and also looking at surgical efficiency as well. Let me see how we can get this to work to start. Okay, can you get this to work? It doesn't. Okay, so these are my positions. I mean, obviously, I'm full-time practicing in NHS at the moment, and also actively involved in education of students and surgical trainees. But the thing which I'm most proud of course, I'm proud of what I do, is what I, okay, if they can get that going. So really, I'm involved in a lot of patient charities and patient events as well. So I think talking about the social media, it is extremely important how we engage with the patients. You can't really do the standard way of what we used to do. So touching, just briefly going out of my talk, we engage with celebrities about organ donation and transplantation. I even did a live transplant in live on TV. That was the first time it was done in Europe. Nerve-wracking for me, but patients and everybody understood exactly what it means. So next time when we talk about organ donation or transplantation, people knew, and they write to me saying that, that's very interesting that now I know, even the patients who had transplant, they were able to say, oh, this is what was done for me. So I think it's extremely important that we engage in the language and the mode, what is convenient to them, rather than what's easy for hospitals and teams. But what's my passion? This is what my passion is really. We need to really empower patients. We need to empower them the way they can decide about their healthcare, how they can be inclusive in every aspect of their care. That's starting from the education to sort of understanding of the problem and taking every step of the way they need to be empowered. And second thing is we need to really enhance certain elements of it, which is looking for solutions outside of the system. When I say that, we need to look for innovative solutions or innovation-based solutions. Look at how we can integrate it. There is a big misconception in relying on partnering with industry. How can we do it? How can we make these things happen in a way which is much more easier so that the industry can trust to come into healthcare as well? Often when people come and talk to us, if people are not engaged to this conversation, they will say, oh, that doesn't work. Or it's like, oh, it's going to work for a few days and it's going to stop. So there's always that hesitancy. So I constantly strive to get this process, and I really enjoy doing it. In this talk, I'm going to talk about chronic kidney disease, which is what I mostly deal with. We're going to talk about two innovative solutions. One of them we have finished the project, another one we are doing it as we speak. And also I'm going to touch upon the surgical efficiency, because if the surgical teams can be efficient, then the manpower can be allocated to other sources. So I'll talk about one solution, and that is what this contraption is all about here. And I'd like to reflect with you all what I think is need to be done to make this innovation work or the partnership work. And I'll conclude. Kidney disease, everybody knows it's a global burden, and the case numbers are going up across the globe. And the patients who have kidney disease, they have a terrible life. It's extremely difficult. They have a very restricted life. But what are their choices? They can have a renal transplant. They can have what we call as a hemodialysis, which is really your blood is taken out of you, passed through a machine, and then comes back to you, and 2 to 3 times a week. Or you can have something called a peritoneal dialysis, which is a tube placed in your tummy, and you do them. But it's not that simple. I mean, the treatment options are there. we as clinicians and the teams, we can do them. But the problem is for transplant, there's a long waiting list. So we lose 2 to 3 patients every day in Britain because they are on the waiting list. They made to the waiting list. They are fit for transplant. There are no enough organs. If it's going to be hemodialysis 2 to 3 times a week, and the other restrictions, they have to come to the hospitals for tests. They have to come in to see clinic doctors for clinical appointments. So they never really have any control of their life. A lot of my patients tell me that is what it feels like. The day we tell them you have kidney failure is the day they feel there's a big shackle put on their feet. And that's it. They don't have any leeway, that they can't negotiate. They can't talk to us about what they want to do. Now, I spoke about what are the challenges are, but unfortunately, I don't have kidney failure. But can I really share what exactly is to have a person with kidney failure? So here I'd like to introduce Belinda Otis, one of our amazing patients. And Belinda is really an editor, journalist, and she's an active campaigner to promote organ donation and renal failure. Belinda.
My name is Belinda Otis. I currently live on dialysis. When I'm done here, I'm heading straight to the hospital for my evening session. I started living on dialysis when I was 16. I'm 42 now. I've had 2 transplants. My first transplant lasted for 15 years. Dr. Rajesh did my second transplant. He's a great surgeon. It's just that the kidney did not take. So after 8 months, I had a retransplantation. Unfortunately, it didn't go according to plan, so it ended up becoming a nephrectomy. Since then, I've had 2 more nephrectomies to remove 2 kidneys, which luckily for me, they were cancerous, but because they were caught early, I'm now a candidate for another transplant, which will be my 3rd transplant. So like Dr. Rajesh said, we do have to wait a while. I've been back on dialysis since 2018. I absolutely hate dialysis. For me, it is a thief of time and it steals your joy, but you have to find ways to live and ways to manage. My life is very restricted in terms of fluid allowance, what I can eat, when I can travel, where I can go, and all that. And being that I live in the UK by myself, you need a lot of support and a lot of help. And my friends are great, but still, no matter what other people do for you, living on dialysis, it takes over your life. And if I go tonight, by tomorrow, I need to sleep until about 12 before I can get back to my normal self. But I try to work. I still work. I came here from work and I'm going to dialysis. So it's that routine every week. And I think for me, as someone who lives on dialysis and trying to live a normal life, since we're not in a technology world, and technology is helping us to leapfrog innovative solutions. So I'm always looking forward to ways in which, things that can help me. So for example, I recently tested positive for COVID. I'm not positive right now, I swear. And so that meant I had to go dialyze in a different unit that is very far away from home. But if I was doing home dialysis, it would have made my life so much easier. So I was saying to Dr. Rajesh yesterday that my resolve is now resolved. Forward to the process of that starting next year. But I'm going to hand over to Dr. Rajesh. Thank you.
Great. Thanks very much. Thanks, Belinda. I mean, that is amazing, isn't it? That is just amazing. I mean, that is what drives or inspires a lot of us, and inspires me really to find solutions. We have been sort of talking about and have done well in patient-centered care, but that revolves around patients having all involved in all aspects of decisions and their care. But still, it is hospital-based. There is a biggest limit. They have to come to see me to have the patient-centered care. So you think about how does that work? Then, of course, it's a single time point to say they turn up, we do the assessment, and then they're gone. In your practice, you do them, and then you don't see them. So there is no continuum there. And of course, it means how can a person can do self-care if there are so many impediments to do that? And if you add the other part, equity of care in that to it, depending upon where you live, which part of the world, which part of the city, which part of the country, it matters. So therefore, there is a serious problem in us delivering the care in the way what we do. And that is where the remote health has to be there. So here I'm going to focus on one specific area where we are doing some work. I mean, and really it's looking at what we call as a dialysis access to have dialysis. I'm going to talk about two projects. One is really to see whether the nurse can do an ultrasound instead of coming to the hospital to have an ultrasound, on how that transforms care. Another thing is to really look at, it's an ongoing project, which is a non-invasive measurement of blood tests, how that will transform our healthcare. So really, just before going into the dialysis access, it's what we call as arterial venous fistula. It is really a procedure done by us, where we join the vein to the artery, and then the vein becomes bigger. So therefore, every time the patient comes in, they can pass a needle through to it so that they can have dialysis using that fistula. That is a physiological abnormality. We shouldn't have that. We create that to maximize the chances of having a safe dialysis. But then that means it's bound to have problems. The tendency is to fail. And for patients who have these fistulas, they end up in having 2 to 3 procedures to keep that functioning. So therefore, there's a huge pressure on patients. And more importantly, every time they have a problem, it needs a specialist input. So there is a biggest problem is they may know what's going on. Patients will think that, oh, I have a problem with my fistula. They have to call the hospital, come and see the specialist. Then we start the plan of what do we do for that? And then we do the surgical rescue. This has to happen fixing around the other normal commitment, which is what Belinda said, 3 times a week, half a day of them is committed. So therefore, I think it's really makes it very, very difficult. And also it depends upon the patient's knowledge and experience. How good are they? How good is the staff to find a problem? The time from the time when the problem has occurred to time to diagnosis. And of course, what that means to the impact of the patient. Now, we researched a lot about how we can make it more efficient, and we have found tools, but they're all based on the system-based tools, not innovation-based tools. So really what I wanted to look at was, can I get my nurses to do ultrasound? Can I train them to do ultrasound, not replacing a specialist sonographer, to see whether they can identify a fistula, whether it's working or not, can they locate it or not? And if they can locate it, can they use it to needle the fistula? So really what I did was brought down the objectives from a specialist sonographer to a basic bedside care. And what I did was, the concept was that to really see if the nurses do the ultrasound using a probe which is easier to be or more accessible, then can that make a difference? So currently the ultrasound machines are about 15 to 18,000 pounds. It's very similar to half the size of these stacks. It's not very mobile. So I started seeking out for solutions and found this. So this is an ultrasound probe, which I can scan with my phone app. And what that means is really, I don't need anything. I just need these two to do it. So they said it's a live demo. So I'll try to see whether we can scan on one of you so that we can see whether we can spot the vessels, And the idea is that this should change the way the ultrasound is done. Now, what that means is really we don't need to worry about waiting for a scan machine or waiting for something else. And what we wanted to do was in the project, what we did, we trained 5 dialysis nurses, and the idea was for them to really locate the fistula, find out why they want to use the fistula. We collected data on them, and also we looked at the outcomes of their decisions and the staff and patient satisfaction. So, and this probe is commercially available, so it's something which I always ask questions on the social media, as you rightly say. I throw away open questions on the LinkedIn. And sometimes people contact you and say, oh, I've got this. What do you think? So it's really one of those things worked out that way. It is still connecting, but I'm going to carry on with the talk, and I guarantee you I'll show you at some point. So which means really we started this project, and we recruited about 50 patients. It took us about 3 months time for the study period. What that means is really the patients were willing to have the scan, because for them in their mind is I don't need to go to the hospital, so I can be here, so I can do this without really needing to be visiting the hospital for the problem. So the main reasons why the nurses use the fistula was really to see whether the fistula is usable, whether it's big enough. The current modality is to feel and see, oh, that feels good, I think it should be okay. That's what we normally do. So with the device, the nurses were able to do the one step, they take the next step, they can say, oh, I can see the fistula, so therefore I think it is usable. Second reason was assessing the fistula, patients for fistula as well. At the moment, if a person needs a fistula, they have to come to the hospital to be seen by us. So they were doing the assessment. So therefore, the patient doesn't need to come to the hospital for that. And the third purpose is really to use them. So they can keep the scanner and then scan and then use that as a guidance. So it certainly made a big difference to what we will normally do, where for every one of these problems, they'll be coming to the main hospital in my trust. And of course, how did we do that? After the training, majority were supervised. But as the time went on, they started doing independent scans. And when we looked at the number of independent scans done and their outcomes, it was really impressive. Nearly large amount of patients, they were able to stop them going into the main hospital. And that was really, I didn't expect that to be so good. And these are nurses with no background ultrasound training. But because we made the objectives very simple, because we didn't want it to make it a lot more complex, and give them a tool which really helps them to use that option and use it easily, it made a big difference. And the groups, there are patients who was scanned by them, but they still need to go for another scan. But you can see that there is a big change in the way the service is done there. So therefore, I mean, that is the biggest advantage. I mean, I was quite surprised, at the same time excited that it is possible. Now, I need a volunteer for me to scan. So who's going to come? Do you want to come along? Okay, you want me to scan your... Jeremy, can you hold the camera onto the phone, actually? Yes, so that... Yeah. Yeah, you can just, if you hold the camera onto that one, just your arm. We don't want to scan this any other part of the body, isn't it? So if you look at that screen, that's my phone, and that's the app on the phone. So what I'll be doing is I'll be doing live. I mean, let's see whether we can find his blood vessels so that we can really see whether he's got a...
I'm actually an Android robot.
Exactly, that's what we're going to find out.
What the hell?
And I think that that's okay. I think the idea here is that, oh, sorry. Yep, there we go. So you can see that. I don't know whether you could see. Now, can you see the round thing right on the top? That's his artery. That's his artery right on there. Can you see it pulsating there? There's a black round thing. So that's really what you see. That's the artery. And then that's the vein. Now, if I add the color to it, just give me... No, it's okay. We can do that here, actually. Yeah, we can do that. Don't worry. I'm going to put the color on, actually, so that it's easy. Don't worry. No, that's okay. So now I'll put the color on so that it won't be that difficult. So there is a...
I've got blue blood.
No, you got the... If you can see that right in the corner there, his blood vessels, yeah. So he's alive. He's human, as you can see.
No, I'm a robot, but I put this extra layer of protection.
So you can see that. So it's really color, and then you can see that probe being done. Now imagine, I hope you never need a fistula, but imagine if the fistula is not palpable, a person can do this. And they can do that. The nurses can do it. Thank you very much.
Thank you.
Thanks very much for the help.
Don't clap, everyone. It's fine.
So you can see that this can be used, and the cost of it is significantly low. So therefore, I think it transforms the way we offer the additional help to the patients. But what do the patients say? The patients said that was really great. I don't need to go to the hospital. They're offering it to me. But they know that still they may need to go to the hospital when there's a problem. Staff, they were felt empowered. They said, oh, I can do this. So they were excited about it. They felt that the patients was coming towards it. And what was amazing was that some of the patients were asking the staff, when can I do this myself? I mean, how cool is that? So really, what I found was that in this study, it's a pilot study, is that it is very clear that as far as the objectives are limited and simpler, you can integrate innovations into healthcare. Often people get muddled about what do we need to achieve. And I don't need to go through the whole benefits of the scan. If you define the purpose, such as this, you can really transform what we do. Our plan is really for the next year. We're going to be starting a large patient with a NIHR funding about a large-scale project. There, I want to look at cost effectiveness. And part of that study is going to be getting patients for base point-of-care ultrasound. That'll be amazing. If they walk into the dialysis unit and say, oh, I can't feel it, can I do my scan? And also we are looking at maternity and community-based scans as well. So therefore, community nurses coming along, they won't just come on field. They may have this or different probe for that matter. That really enhances the opportunity of what can be done. So moving on to my next project, which is really non-invasive blood test. So that's what can be done in the dialysis center, not coming to the main hospital. But still, patients need blood tests. Patients need to be having blood tests done on a regular basis. They have to come to the hospital for it. It is invasive. So what do we need? I mean, this is another what we call as an unmet call. So we put the unmet call and say, can you find a solution for me? And then there is an American company contacted me and said, oh, we may have a solution. It's called Alio Spot Patch. It's this patch over here. It's now, this is the third prototype, and we worked together and developed a much smaller one. So it won't be this big, the next one coming in 22. And the idea is that we can measure these things. So of course you have the Apple, all the watches, which can tell you temperature, oxygen saturation, heart rate variability. What we went for, and that was the question I asked them, I don't want my patient to come to the hospital. So can we measure hemoglobin? Can we measure hematocrit? Can we measure creatinine? And at the moment, we've got these three. And the project, what we are doing is really to look at this patch, put it on there. It can be done anywhere. Now, when we put the patch on, the data goes to Colorado. And then, obviously, it is a blinded project. So from the researcher's point of view, but still, that ability is there. When we looked at the pre-validation work, their work in US, they were able to show hemoglobin and hematocrit at a very good accuracy. And the same with the potassium as well. These are essential blood tests which are done for the patients on renal failure. And if you extend that sort of indications to chronic heart failure, and sort of so many areas where it is applicable. So therefore, it is definitely something we wanted to look at. And I was so excited to launch this project a few months ago. So we are now, we and the new team in Newcastle, we launched a project on only adults only with patients on fistula, where we put the patch on when they come for the dialysis. At the same time, we do their blood tests as well so that we can see the validation of it. To date, we've got 35 patients, and patients like it. Patients say there's no hassle to it. It sticks to them. It can stay up to 9 days if we need to, but we keep it for about 3 hours of the dialysis session. And what I really wanted is not just one point value. I wanted to have series of point values so that we can have a reference point. Because if you have a blood test saying it is 4 millimoles, is it just at one point when we measure? It'll be good to have an average, like what we do for a heart rate. You want a heart rate variability. So there was no issues and the staff were able to do it. And what we found was that these are the number of patients and their age groups as well. And there was no serious issues what we found. But what patients said was these things, which was quite amazing. Patients were saying that they felt like, oh, somebody's looking after me in the sense that not just physically, we are having the blood test as well. And a lot of patients said, can I take it home so that I can sleep peacefully knowing that the hospital is looking out for me? I mean, that was amazing for me to hear those feedback. The results we're going to be analyzing early, but I was fortunate enough to roll out one of them, which is really a live of one of the patients what we did. So you can see that it's a whole trend. Over 3 hours, we get the results. So you don't have the single value. It's a whole series of values for that. So what that means is, I think we definitely know that in the American pay validation work, it works. We know that in our early results, it is working. But what really excites me is the opportunity for patients to be looked after at home. They don't need to come into the hospital to have anything done unless there is a problem triggered by home. The other thing we are working on is to really get a patient alert as well. So when the patient has a patch at home, there will be an alert to the patient saying, oh, your heart rate is going up. That we know iPhones can do that, or other phones can do that. But what will be quite nice is if the potassium is high, do they get an alert? So that's what we are working on as well. So it's really exciting that we are able to enable the opportunity to have sort of blood tests in a non-invasive way, more at home as well. And our intent is to combine these two, access care and blood tests, 2022 with the NHSX. We've got a grant to launch it out. And of course, once the MHRA is approved in UK, I expect this will definitely be part of standard of care for our patients. So moving on to my third one, where the contraption is, it's really looking at surgical efficiency. The reason for making the surgical teams efficient is really to make sure that the care offered is much more streamlined. There are various things I'm working on, but I'm going to focus on improving the surgeon's efficiency. how can I be more efficient, or my team can be more efficient? One of the procedures I do is the laparoscopic procedure. It's increasing demand across the globe. There is more number of cases need to be done, but there are not enough assistants. So you have to have 2 surgeons to going to do the procedure. So I started looking for, can I find a solution? And Jeremy here, who's the CEO for the company called Freehand Surgeon. So we started working together to look and see, can I start doing single surgeon laparoscopic surgery? That was the idea, which means my registrar can do something else, allocate time for somewhere else. So what we did was the aim was to look at how much time we can gain in performing this surgery. So the design is very much looking at all the metrics, mainly looking at how many time saved, how many minutes saved in performing this procedure. And we used a sort of task index, which is used by NASA in measuring impact of the machine on the performer. So really, when you look at it, we collected about 50 patients in the study, 25 on each group. There's no big difference between both the groups. What was quite amazing was the time. I mean, this one takes about a bit longer to set that up. As you can see, Jeremy was trying to set that up during the talk, but still the overall operating time was lesser. That is simply because I don't need to tell somebody else what I want. I can just do it myself. And more importantly, 26 hours of my registrar's time was gained. Now that's a very precious time. It can be allocated somewhere else. So therefore, and when you look at the impact of it, this is really by the case. Initially, I was a bit physically and mentally fatigued. But as the time went on, I was quite comfortable using the procedure, and also the complexity of the procedure, which are the taller bar diagrams, that started going up as well. So this means really you can perform this procedure with the aid of the freehand safely. More importantly, it allows time for the team to be more efficient. And that means the surgical care of the patients improves more. And we are planning to sort of launch a study in Jan 2022, where we want to look at the ergonomics of it on cost effectiveness gained by this. What this means is really, the idea will be here is to make this as a standard of care in the surgical practice, not just in UK, beyond as well. Jeremy, do you want to just show them quickly so that, so what this means is really once the scope is launched, I control the scope with my head movements. So when I move the head, once Jeremy is connected, I'll show you. So what that means really, when I want to move left, I just move my head to my left, the camera will move. Move my right, I can zoom in, zoom out. So it really, really makes it easier for me to do laparoscopic surgery. Not that my assistants are any bad, but it just means that I don't need to, it takes a lot from that perspective. So if you just look at the screen now, so you can see that. So I can just do that way. I think we're running out of time, so I'm going to sort of make it faster. So which means you can imagine, I don't need to do that. Now both my hands are free. Now in a robotic surgery, I have 4 arms. I don't have 4 arms, but in robotic, we have 4 arms. So you control all 4. So which means really, you don't need to worry. One of the questions is the registrar is going to lose out the chance to train? No, definitely not. We're going to train them better. I'm going to get them to wear this. So instead of me standing on the shoulder and saying, do this, do that, I can observe from far and measure them properly about how their training is and how they can do it. Now, therefore, I think, it's certainly transformed in the way we do things at Bot Health. So it's really being rolled out to other process as well. So you can see that I can zoom in, zoom out without really too much transition. Thanks, Jeremy. Yeah, so I think there is no doubt that the innovations, if we are asking the right questions, and if it can be done in collaboration with people, it can work. And there is a need for us to do it. Every time when I sort of introduce these things, and I always reflect about why do I do this? Because I have a full-time work and I'm actually crazy that I don't want to sleep anymore. But I think it's really rewarding when I see people like Belinda, where I can say that, oh, this solution is there. And we were talking yesterday and she was saying that, oh, if this is there, I will consider doing that. And she was engaging that. And I love the fact that you can seek solutions, put messages in LinkedIn and say, hey, what do you think? Or ask people's technology. They design for something, and then we can ask questions. We can look at other benefits of what can be done and empower collaborations. And of course, we need to improve engagement of healthcare professionals. But we do need to talk about this. We need to share this widely. This event is an amazing event where I'm so glad that to share some of the things what we do. But we need to share this widely. We need to ask the journals to write more about it, because the hesitancy is on the healthcare side, not the innovators. Their hesitancy is, how can we approach these guys? They always say no. Most of the time they say no. I think it's really breaking that wall. And I always say that we don't have time. We have to change. I think since the COVID, we saw patients' acceptance for technology and remote care. I don't think we have that excuse anymore. We have to be able to change it, and we need to change the way we do things. So I would like to conclude by saying this. Innovations used in the right way certainly transforms what we do, and it can definitely make the healthcare systems efficient. I will leave with this last slide, which is really what my vision is. And I think you might have seen these slides before, that patients care starting at home. Before they come in, you get to know the information. If I can tell you, I'm working on 90% of what is mentioned there at the moment. And 2022 is something I'm excited about. Because this means the patients can be at home. They can wear this. I will get the blood test. I will get the OBS. I will know what to do. If they need it, of course, and then by the time they can have a video consultation if they need to. By the time they call us, we will, as soon as they call us, we will have their information. So we can say, oh, by the way, why don't you do this? Oh, no, you shouldn't. You have to call the ambulance. But the information is more objective, not what I feel from the doctor's perspective. And of course, when they come to the hospital, we are not starting from zero. We are starting from maybe 30% of the work done before they came into the hospital. So I think for me, this is really, I feel that this used to be a dream to a certain extent, maybe 10 years ago. And I think things have moved forward significantly. But now we are at a point where we really need to accelerate this. We really need, in the next 5 years, I expect, and I feel we owe it to our patients that we definitely need to change the way we do things. Thank you, everyone.
Thank you so much. That was absolutely fascinating. And I think it's a really good segue into the presentations that you guys will be making in a moment. What comes across for me is that passion, a clear understanding of the problem. When you're thinking about your ideas, actually, here's somebody who's doing that in real life. So absolute expert in what he does. You know, understanding of what patients' needs are directly, having some infrastructure around him, collaborating with other people. And I'm sure you've had plenty of failures and knockbacks, and so, you know, it's not all magically happen. So, you know, it's a tough gig, but it's worth doing, I think, overall.
Yeah, exactly. And I think I have to say that it's our patients really what they make the difference. So when I have an idea, when people come and talk to me, I never say, go away. We just talk about it. That doesn't mean we're going to go to the next step of writing something down. And immediately I talk to our patients and say, hey, what do you think? So there is a word, I always see that the user word is used very broadly. End users are them. They are the experts. So I get that feedback directly before I go to the next phase. So any innovation comes to me, I'll say, fine, give me the solution, give me the plan. I'll talk to my patient groups and then come back to them. Belinda, would you agree that's the best way to approach?
I'm not sure.
Thank you. Yeah. As a patient, you are an expert on, you know your body better than anyone else, and you know your symptoms and everything else that comes with it better than anyone else. So it's always a plus, an added plus when you have a doctor who listens and hears you out and not just tells you do this or do that, because sometimes what you need as a patient is very individual to you. What might work for you might not work for someone else. For example, I've had 4 fistulas done and none of them are currently working, and I'm quite nervous about getting the 5th one in case the same thing happens. But this new technology about being able to manage your fistula at home and to see how healthy it is or if it's pulsating or not, that kind of takes away the fear factor.
Thank you. And there are risks associated with trying new stuff. There's risks for both of you. And actually, it's about mitigating some of those.
And also, Jeremy will tell you, talking to clinicians, it's not the easiest thing. Getting us to agree to things are not the most challenging thing. But what are your thoughts on Jeremy?
Well, I think the whole success is when everybody works together. you need to have the clinicians who are committed. You need to have the patients who are willing to get engaged. And then you need to have the engineers and the designers and the technologists who can bring it all together. And I think if you get one on their own, it's normally a disaster.
And we've got plenty of those around. So, and I think maybe the thing that, I don't know, like Lord of the Rings or something, you need to have like that one ring that binds them all. You need to have the absolutely crystal clear vision of what you're doing. Then suddenly, you know, everyone can work together, and that needs to be articulated. I'm conscious of the time. Has anyone got any burning questions? You will hold the group back if you do ask any questions. Just putting it out there. Good. So let's take because we got the presentations. Let's take a 3-minute comfort break. And the reason it's 3 minutes is because that's how long you lot have for your presentations. So 3 minutes, and then what we'll do is we'll call you up in order, and we'll talk through who's doing the presentations, and then we'll give you marks out of 10. And remember, there's £100 at stake, plus another £50, plus £25. So there's a lot of cash here floating about. You can buy an awful lot of student things. On Black Friday, that money is multiplied. Is it Cyber Monday? Is it not carrying on? Oh, well, we should have done this yesterday, shouldn't we? All right, a couple of minutes comfort break, and then we'll get the cues.
Hi.